We're all chuckling here because, as usual, technology is beating us over the head with a rather large hammer. Thank you everyone for coming, and welcome to everyone. My name is Dr. Gregory Boyce. Welcome to HIV SCI, Mrftt HIV SCI Echo. It's a very eventful time in our country, but we very much appreciate the fact that you were able to come and spend some quality time with us, learn something, interact, and build community. So in the hub with me to my left is Dr. David Booster. To my right is Belinda White, who's a clinical psychologist and who's going to present today on personality disorders, a broad overview. So everyone, sit in, strap in, and enjoy the session. Thank you so much, and Belinda, over to you.
Thank you, Dr. Boyce. So today our presentation, as Dr. Boyce mentioned, is going to be an introduction on personality disorders. The intention of this presentation is to make it one that is continuous. And so the next time I present, it will also be related to personality disorders, but more specific. And this directly, of course, relates to the case that will be presented after my bit this afternoon. Go ahead. All right, so of course, this presentation is not intended to be a substitute for professional medical advice, diagnosis, or treatment. I'm nothing further to declare. I don't know what else. And so we move into the learning objectives for today's presentation. It's going to be pretty much very straight to the point because it's just an introduction. And so the first learning objective would be to define personality disorders according to the DSM-5, to identify the personality disorders that are included in DSM-5, to discuss the differences between DSM-4 and DSM-5 and how they identify personality disorders, and to review the most common treatment approaches used for personality disorders. So we're going to go ahead with the definition. So according to DSM-5, a personality disorder is a persistent pattern of internal experiences and behaviors that differ significantly from the expectations of an individual's culture. This persistent pattern of internal experience and behavior can be identified as pervasive, inflexible, consistent over time, causing distress or impairment, and has an onset in adolescence or early adulthood. So, no, go back again. So the list at the bottom there hints to the criteria for a personality disorder. So sometimes you may run into some difficulty when you try to differentiate a personality disorder from another disorder. And these are the markers that are really important to consider. So the pervasiveness of the internal experiences and behavior that significantly differ from the expectations of an individual's culture, right? That is also inflexible, has remained the same over time, causing significant distress or impairment, not only in one facet of their life, but in numerous facets of their life, whether it be their social life, their work life, etc. So numerous domains, we find that there's some impairment or distress. And then we also look at the age of onset. We can move ahead. So this is a bit from the American Psychiatric Association that describes an individual's personality, right? And what it is influenced by. So it's influenced by life experiences, an individual's environment, for example, their surroundings, and inherited characteristics. So of course we have that sort of biological aspect to a personality disorder or a psychological diagnosis, right? We always have to consider that biological component. And further to that, personality disorders may affect at least two of the following areas. Now, I want us to pay particular attention to these four statements because it rings true for every single personality disorder, as simple as these statements are. So the first is the way of thinking about oneself or others, way of responding emotionally, way of relating to other people or way of controlling one's behavior. So I'm going to make reference to these 4 statements as we move through the various personality disorders that are presented in the DSM-5 because they're really critical to identifying how these personality disorders present. Next. So in DSM-5, we have about 11 personality disorders that are classified in clusters. And these clusters are sort of grouped based on the similarities that the personality disorders share amongst themselves. So we begin with cluster A, which has 3 personality disorders, as you can see. And this cluster may be defined as odd or eccentric, right? So significant social withdrawal and awkwardness are common characteristics which often result in relational issues. And the personality disorders included in here are paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Now, given our maybe surface or superficial knowledge of personality disorders or mental health, the diagnoses that go along with psychiatric disorders, I just want us to think back to those 4 statements and really ask ourselves which one of those may apply. So remember the 4 statements, they relate to how we think of ourselves and others, how we manage our emotions, how we control our behavior, and how we relate to others, right? So there must be at least 2 statements that are relative to these 3 personality disorders that are included in cluster A. So I want to encourage you all to type in the chat, what you all think. What statement do you think is most relative to this cluster? So I'm gonna go ahead with this one. We have 2 other clusters to go through. And so I want to encourage you all to reference that list and put in what you think. So for cluster A, the statements that apply most would be related to thought, right? So the way an individual is thinking, thinks about themselves and others. And of course, if you are familiar with schizophrenia and the related disorders to schizophrenia, that is a thought disorder, right? And so the words paranoid, schizoid, and schizotypal, they give that hint. They give the hint to the individual's thought processes of themselves and others being skewed, having them experience an alternate reality to an extent. Yeah. So all of these personality disorders, they contain suspiciousness and distrust toward others. Of course, that is clearly stated in a paranoid personality disorder, right? Because if you're paranoid, you're going to be suspicious of others. And of course, because you have these skewed thoughts of others and yourself also, is going to cause a significant impact on your relationships. And so it's very difficult for someone with any one of these personality disorders to have a healthy, well-functioning relationship. So another similarity that all of these personality disorders share would be that they do not occur exclusively during the course of schizophrenia, bipolar disorder, or depressive disorder with psychotic features, or another psychotic disorder, and is not attributable to physiological effects of another medication. So the reason why I say this is because with mental health, you find that there are many similarities. You may encounter a client that presents as schizophrenic, right? Or having another thought disorder. But it's important for us to look at their presentation, because it may be that their symptoms or their presentation is so pervasive that it may qualify as a personality disorder. And so it's important for us to be able to differentiate between the two. So when someone has a personality disorder, yes, they may mark off the criteria for another disorder like schizophrenia, which is fine. They can have both at the same time. But interestingly is the criteria for the personality disorder remains. even after the psychotic symptoms are in remission. So let's say, for example, we have a client come to us, they satisfy the criteria for schizophrenia, and we treat them, right? They place on antipsychotics, etc. And remember, these psychotic symptoms that we're looking for in schizophrenia would be hallucinations, would be delusions, right? And oh gosh, I forgot the other one. It's hallucinations, delusions, and
hallucination.
Disorganized behavior.
and no, not disorganized behavior. I forgot the other component. There are three thought components. I'll get back to you with that one when my mind catches up. However, let's just say, for example, the individual presents with those that impairment in their thought, right? And we address it. So we refer them to the psychiatrist, they get their antipsychotic medication, etc. However, their behavior persists, right? Their doubts in other persons, their suspicions of others, their relationships are not improving, their functioning within their life is not improving. Then we have to look past schizophrenia, right? That initial diagnosis, and say, maybe there's something else going on here. And we could consider a personality disorder, yeah? So now we're going to move on to cluster B, which is the most commonly encountered cluster because it contains borderline personality disorder, which is very frequently encountered in primary healthcare settings. So cluster B may be identified as dramatic, erratic, or emotional, and significant difficulty with impulse control and emotional regulation is common as well. So there are 4 personality disorders included here, which would be antisocial, borderline, histrionic, and narcissistic. Now, we're going back to those 4 statements at the beginning of the presentation. The 2 of those 4, which would apply most to this cluster, would be taken from that very first line that talks about dramatic, erratic, and emotional behavior, right? Would be the statement that is most applicable would be the way an individual responds to their emotions, right? And then the second one, which I think applies to all clusters, would be how they relate to others. And another one would be how they control their behavior, right? Because we have impulse control in that first statement. And so referencing those 4 statements at the very beginning of the session, it sort of reiterates how important, even in the simplicity of these statements, it reiterates the importance of it for us to think to ourselves, what exactly is this personality disorder presenting, right? And so the similarity between, among all of these personality disorders are just that. The individuals have a very difficult time with managing their emotions, and of course, emotional management includes identifying emotions, coping with emotions, expressing them, and identifying them in others, right? And so they have a real difficult time with doing any one of those stages of emotional management, which of course would impact their relationships as well. It's very difficult, for example, for someone with borderline personality disorder to have a relationship, as well as antisocial personality disorder. It's very, very difficult for them. So I particularly want to point out antisocial personality disorder and borderline personality disorder because both of them are significantly challenging. The reason being is that with borderline personality disorder, you have marked mood, behavioral, and self-management instability. So it's very difficult for someone with borderline personality disorder to, as I said, manage those emotions, control their behavior, and sort of regulate themselves and how they see themselves. Many times someone with borderline personality disorder, their self-image is very dependent on external sources, let's say an external relationship, right? And so their self-image sort of fluctuates. It's never a stable image that they have of themselves. And on the flip side, antisocial personality disorder has a lack of regard. An individual with this personality disorder they display a lack of regard for others' rights. And they're also very impulsive and irresponsible. However, they seem to not experience guilt. So whereas somebody with borderline personality, they are very impulsive and they behave very erratically. They may experience some guilt when they realize, that they've harmed someone or they've infringed on someone else's rights. Not that they may have the capacity to address it or fix it, but they experience the guilt, right? Whereas antisocial personality disorder, they don't. And so I think that explains why it's so difficult for someone with antisocial personality disorder or borderline personality disorder to have really thriving relationships in life. Because it's very difficult for them to just manage those impulses, manage those emotions. And of course, those are two very key components to having a relationship in any setting, whether it be a work setting, school setting, in a romantic relationship, even with your children, any type of relationship, these components are very important. And so these individuals would run into challenges. So now we can move on to the final cluster, which is cluster C. So cluster C can be described as or identified as anxious or fearful, and they bear symptoms that coincide with mood disorders. And it contains avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. And I just want to point out that obsessive compulsive personality disorder is very much different from obsessive compulsive disorder. While there's an obvious similarity in their name, they are different. Yeah. And so the commonality here, let me reference those 4 statements at the very beginning of the session again, as it relates to thoughts, emotions, regulating behavior, and relating to other persons. Does anyone want to say which of those 4 statements could be identified in these 3 personality disorders here? Which of those 4 statements do you think is most applicable? Do you think the individual will have difficulty with their thoughts of themselves and others, difficulty with managing their emotions, difficulty with relating to others, or difficulty controlling their behavior? Relating to others, okay. Dr. Musa, who was not listening?
I'm listening actually. They would also have problems controlling their behavior.
Yeah, yes, they would have problems controlling their behavior. So Dr. Boy said difficulty relating to others, and Dr. Musa said difficulty controlling their behavior. Of course, both are correct. In addition to, they have challenges with how they view themselves and others. And so with avoidant personality disorder, you find that this individual presents in a very anxious way, and they literally avoid situations because there's a feeling of insecurity and inadequacy. And so they are, let's say, for want of a better word, extreme in avoiding situations that may be triggering for them. Dependent personality disorder, again, self-explanatory, the individual becomes very dependent on persons around them, aka clingy, right? And they experience significant separation anxiety. And next is obsessive compulsive personality disorder, is where the individual experiences or displays obsessive behaviors and compulsive behaviors, but it is not limited to physical, tangible things. It's not limited to one environment. It is pervasive. And so that obsession and need to control, it goes throughout their life. It goes through relationships within the workplace, etc. So if you've ever seen someone with OCD, obsessive compulsive disorder, you may find that their obsessions are specific. So their obsession may be with order, and they're unable to complete a task unless they engage in certain compulsions. So they engage in the compulsions, and then they feel okay, it eases the anxiety, and then they can proceed with whatever task it may be, right? However, an individual with an obsessive compulsive personality disorder experiences this compulsion and obsessiveness, but to a greater extent, right? So it goes into, let's say, for example, they are unable to complete a task in the workplace because they can't delegate to others, they cannot cooperate with others, they cannot hear other viewpoints that differ from their own. And so it's quite difficult engaging with someone with this personality disorder. And at the root of this disorder is also anxiousness, right? So anxiousness and fear. So that's the similarity between all of these three personality disorders. So let's move ahead to the next. So I'm going to pick up the speed in terms of the next few slides. It's going to be pretty brief. So I just wanted to mention that, of course, DSM-5 is a new version, right? So the DSM would have been in existence for some time. And so the DSM-4 would have presented these personality disorders quite similarly. However, something to note is the DSM-5 actually offers an alternative model to characterize and identify personality disorders. So in the DSM manual, the actual manual, there are two sections, section 2 and section 3. And so the section 3 that I'm referring to here is in the actual book. And you find this new way of identifying personality disorders. And it sort of aims to address the shortcomings of the current model, which is used in section 2, right? And so the alternative DSM-5 model focuses on impairments of personality functioning as well as pathological traits. So it's very, very specific. And so, can you go to the next slide? These are the personality disorders that are easily identified with this new model. And of course, this model is developing, right? And I assume when we have a DSM-6, it would be used more broadly for more personality disorders. And so within this section 3 of the DSM-5, there are very, very specific criteria for how each of these personality disorders are identified. And I do think as we continue on with this particular topic of personality disorders, we can look at it in more detail, this new model of identifying and characterizing personality disorders. Next. So finally, treatment approach. Treatment for personality disorder can range from inpatient care, inclusive of medication, to talk therapy. And talk therapy is the most common approach. This is dependent on the type of disorder the individual has been diagnosed with, as well as comorbidities, if any. So I mentioned before that an individual could have schizophrenia and they could have a personality disorder as well, right? And schizophrenia is a disorder that would be treated with medication. So it's not necessarily that everyone with a personality disorder has to be institutionalized and treated with medication, because as I mentioned, talk therapy is the go-to method. So the most common therapeutic approaches include, but are not limited to, cognitive behavioral therapy and dialectic behavioral therapy. I include these two because this is what I use when I encounter a client that has, that presents like they do have a personality disorder. And also group sessions may be utilized and may incorporate family and friends of the client. So that is a very important and significant contribution to the treatment of an individual with a personality disorder. Now, I don't know if you all remember, if you were here when I presented on supportive behavioral therapy, I just wanted to mention that with supportive therapy, I did say that I use that when I can't use CBT or I can't use DBT with a client, right? So they're just not there cognitively, or their insight is not developed sufficiently for me to engage in these modes of therapy. So we could start with supportive. My point is that we are not limited to any one mode or any one therapeutic approach. We can shift our therapeutic approaches depending on the need of the client and how they present at that time. So let's say I meet with the clients and they just don't have the insight yet. We don't have our rapport established as yet. And so I depend very heavily on supportive therapy until we get to that point. And then we move into dialectic behavioral therapy or CBT, whichever is most appropriate. Yeah. And the cognitive behavioral therapy is very critical because, as I mentioned before, a lot of the personality disorders, they contain sort of incongruences in persons' thoughts and how they perceive themselves and how they perceive others. And of course, cognitive behavioral therapy is very much focused on an individual's thoughts. And so that's the usefulness of it there. Dialectic behavioral therapy focuses on behavior. And so, as I mentioned previously, with personality disorders, individuals may have a difficult time with relationships. They may have a difficult time in establishing close bonds with others. And so dialectic behavioral therapy is really useful in those instances. And so we have to tweak our therapeutic approaches to suit the clients that we have before us. Next slide. I think that's it, you know. So just to review, a personality disorder is defined as a persistent pattern of internal experiences and behaviors that differ significantly from the expectations of an individual's culture, and the DSM characterizes them into 3 clusters, which we went through in great detail. So we have cluster A, B, and C, and we have those 4 statements. So you all can read these, the definitions of each cluster, which we already did. But I just want to reiterate the importance of those 4 statements that we mentioned at the beginning, the very, very beginning of the session, which should be an impairment in thought of themselves and others, impairment in behavior and how they manage their behavior, impairment in emotion and how they experience emotions, right? And the way, today. And the way they, did I say behavior already? So the way they think, the way they experience emotions, the way they behave. Go back to the very first slide, Dr. Boyce. Oh my gosh. There we go. So the way they think of themselves and others, the way they respond emotionally, the way they relate to other people, and the way they control their behavior. So regardless of the cluster that let's say you encounter clients and you know, you're not too sure off the top of your head which cluster it's going to fall into, that's all right. Because, you know, when you reach a stage of diagnosis, then you consider the cluster and you go to the DSM, etc. But as the client is before you, the important thing to ask yourself and to identify is, okay, in what area is this individual being impaired? Is it their thoughts? Is it their emotions? Is it relationship-wise and how they relate to others? Is it controlling their own behavior, which suggests some impulsivity issues, right? So those are the areas that we're looking for when the client is right in front of us, you know, and then we could take it a step further in terms of assessing more using assessment tools that are available to us and make the diagnosis that may be most appropriate, and of course refer for treatment as needed. So that's the end of my presentation. Thank you very much for forgiving me for my lapses in cognition. I'm going to pass over to Dr. Boyce so we can go into the case for today.
Thank you so much, Belinda. So before I run into the case, just want to open for if anyone has any questions or comments about the session, about the presentation, sorry. So, so let me just invite persons, if you're not able to speak because of where you are, feel free to type into the chat box. And if you can't submit your questions right now, we'll always try and facilitate later, because this is a topic that I have a lot of, I suppose, interest in, because especially with that presentation, you're sort of thinking on all the patients you have who, you know, that are difficult.
Yeah.
Right. In inverted commas. And you've tried all different approaches and they don't seem to be able to organize themselves, and they don't seem to have some of those access word disorders. psychotic, they don't have, the depression, but they just can't
Yeah.
quite seem to cope
Yeah.
with day-to-day living, and they always, conflict, and always this, always a new scar every weekend.
Right.
You understand? So
Yeah.
I'm wondering, and we had conversations about how frequently you sort of diagnose certain types, especially
Yeah.
like you mentioned.
Yeah.
How, just in your own sort of, thinking, how often are these patients and all different clinical practice? Us here, the doctors at QBCC who have these patients keep coming in with the same thing over and don't take them as.
Yeah.
How common do you think this is in our population in terms of, especially some of those difficult to reach patients?
But I think personality disorders are very common in, especially cluster B. They're very common in primary healthcare settings, right? And the reason for that is we see such a large variety of persons, right? So the pool that we see is so large, and all of the influencing factors that I would have mentioned. So let's say the environmental factors that, let's say abuse, right? Socioeconomic background, etc., is at play in that population. And we also have relations, we also have socialization, we also have the genetic factor. So you find that when you have a large population like this one, you may encounter it quite frequently, just because all of those factors are very, very present. So let's say I've diagnosed quite a number of persons with borderline personality disorder and send them for review. And in my conversation with them, I've recognized that they sort of meet a certain template. So they would have had some sort of childhood abuse, which is a predisposing factor, right? So let's say some sort of sexual, physical, verbal abuse that is quite extreme. Then we have the genetic factor. They may have an aunt or parent who was addicted to a substance, who had depression, who had schizophrenia. So they have that genetic predisposition to developing mental illness. And then also in their current life, they may be experiencing abuse. They may, or in their adult life, would have experienced abuse, even if it's not then and there, So you find that they meet this sort of template. And it's interesting because you come across that template very often. And I really think that because it's a primary healthcare setting where everyone can come, they can't necessarily pay to go to a private institution, we're going to encounter it more frequently. Yeah.
Because of how their underlying mental illness affects behavior and how they access care, they do tend to end up ill at the hospital. Something's going wrong because they're not managing their
Right.
properly, they're not managing their diet,
Right.
and also everything else. So it sort of predisposes them to come into contact with the healthcare system. So
yes, especially let's say borderline personality disorder, where the impulsivity is large, right? I mean, it's so high, right? And the age of onset for these personality disorders is quite young, right? It's in adolescence. Some of them could even be identified in childhood, like cluster A. So sometimes, you see a child behaving strange and you may think they have autism, right? And you take them for review, etc. So that's as early as it could be presented. However, if you have an adolescent engaging in impulsive behavior, which could lead to high-risk behavior, like engaging in unprotected sex, engaging in drug use, etc., then you could find that they are more likely to contract something like HIV or another STI and end up in a place like this, right? Because these personality disorders have been present before they came to us, right? Before they needed our intervention, medical intervention, etc. It's just for us to identify it, and it's quite difficult to treat them. Yeah, because their social circumstances are so grave. It's so expensive that, when someone has significant, and we've mentioned this before, when someone has significant social circumstances and challenges before them, it's real hard to get them to come to therapy, and for them to commit to that, even for them to go to an external clinic to get like an outpatient clinic, etc., is difficult,
Okay, thanks so much again. So we will move to the clinical case now, but again, if anything comes up, we want to ask a question or post a comment, thank you very much. We do appreciate it.
Can I ask something?
Of course.
oftentimes we meet, I meet people, and you can feel they have a problem
Yeah.
and they need further intervention. Now, issues to do with mental illness, most of our people do not have a mental problem, even though it is glaring. And then once in a while, you inform somebody that you want to refer them to a psychologist or a wellness clinic, and they tell you over their dead body, they're not coming.
Yeah.
Some people have had the opinion, just refer them.
Yeah.
My opinion or my take is I will talk them into agreeing that they would go for that service.
Yeah.
Because I've had a few experiences where somebody is referred to a psychologist or a psychiatrist, but they simply refuse to talk because they were not told of going there, or they haven't realized that they have a problem.
Yeah.
What is your view about when to refer? Do you get people coming to you that didn't even know they were coming to you?
Yes, I've experienced that. And they didn't know I was a psychologist. And that's sort of difficult for establishing rapport with a client because they sort of feel sidestepped by their practitioner, right? Like someone lied to them. And so I definitely don't think that's the best approach. I do think as you said, being transparent to the client and saying, well, this is what I would recommend for you. And having them agree is very important because we want them to have continuity of care. We want them to go to the clinic and continue going to the clinic. Want them to go to therapy and not just once, right? So I do think the ideal time to refer someone would be when they agree, right? Yeah. However, in the instance where a client is actively suicidal, you do the referral regardless. If someone is, let's say, experiencing a psychotic episode. So I did have a client once who's actively, she's schizophrenic and actively experiencing these psychotic symptoms. She has zero insight. And so having a conversation with her about the referral wouldn't make sense because she has zero insight, right? And her cognition is totally impaired at that given moment. And so under certain circumstances, you can't forego that conversation about getting permission, etc. When the person is at risk to themselves, right?
Those two people almost need to go to hospital.
Absolutely. Yeah. So that's what I mean, a referral.
I mean, for example, there's a young lady actually referred to and talked about her. Sorry, I didn't come back to you. And she came back, she had an appointment, and I said, well, today you're supposed to see the psychologist. Told me no.
Yeah.
I'm not going.
Yeah.
Let me just talk to you. I'll come back. So I'm still monitoring to see when she agrees and she feels like she'll come.
Yeah, I've had situations like that as well with these social workers, and what I mentioned to them is when the client comes, call me and tell me, and don't tell them. We sort of have to be tactical, right? Don't tell them that, you're going to send them to me on another day or whatever. Just call me and I'll walk to the front where they are and I introduce myself. And that goes a long way because sometimes when they hear the word psychologist and, they think, well, I'm not mad, or you're sending me by a psychologist. No, they think of the psychologist like this big, scary person. But when I come to them and I introduce myself pleasantly, etc., it helps, right? And they may be more open. That has happened where, they say, well, all right, you're nice. You talked to me nice today. So, yeah, I'll talk to you again, so.
Please send a reminder.
Yeah.
I'm
to you?
Because, no, to everybody. Because
okay.
the times when I've been told, just refer them. And I've said, no, I'm not referring someone who doesn't want to go.
Yeah. So sometimes we just have to be tactical. We don't want to be, we don't want to lie or deceive anyone, but we just have to alter our approach sometimes to ensure, that we get the referral done and the client sees, it's not so bad after all. Yeah.
Thank you.